Welcome everybody to Grand Rounds. I'm very pleased to introduce our speaker today, Mary Porteous from the Hospital of the University of Pennsylvania. Dr. Porteous is an interstitial lung disease expert. She's an assistant professor at HUP, and she's the director of clinical research for interstitial lung disease, both at HUP and for interstitial lung disease and sarcoidosis at the Corporal Michael Crescenz VA Medical Center in Philadelphia. So thank you, Mary, for joining us. And the way the questions work, people can put questions into the chat or at the end raise their hands and we'll connect each other to them. Okay, thank you.
Thanks for having me. I'm old school, so feel free to interrupt at the time, or Dr. O'Donnell, if you see something in the chat that I don't see, feel free to stop me. So it's great to kind of join you virtually. My family lives down in Maryland, so I wouldn't have mind coming down. My twin sister is a small animal vet down in Annapolis. All right, so the rather large topic that I'm hoping to kind of at least do some justice to is kind of the ILD for the general internist. So the objectives are to identify some signs and symptoms of ILD, to develop a systematic approach for evaluating them, and review some kind of radiographic and clinical features of the more common subtypes, and discuss treatment. So interstitial lung disease in general is a syndrome of over 200 diseases that affect the interstitial space. So where is that when we talk about that for the medical students? So it's at that interface between the alveolus and the capillary bed. Anything that sits in this kind of space here, whether that be inflammation or fibrosis, can impede the natural flow of oxygen across that membrane and can result in less oxygen in the capillary bed, hence lower oxygen level in the body, lower oxygen saturation. And these diseases have a variety of physiologic effects. So because of the either fibrosis or inflammation that's present, it can reduce the compliance on the lung volumes, and that can result in some restrictions seen on spirometry. It can further reduce the diffusion, as I mentioned, of oxygen, and that results in a lower diffusion capacity, or DLCO, as well as hypoxemia. These present kind of unfortunately non-specifically with just dyspnea and cough, which makes them a kind of a really difficult diagnosis to make initially. So I'm hoping to get across that, albeit rare, ILD is kind of an important cause of dyspnea in the kind of big proverbial bucket of causes of dyspnea. Should have made my droplet bigger. So the prevalence of kind of even just one of the subtypes of interstitial lung disease, or IPF, is kind of 10 to 60 cases per 100,000 in the overall population. These diseases commonly affect elderly patients. And so if you look at kind of just the subgroup of, I don't say elderly is above 65, as I get older, that's kind of shifting a little bit more, but kind of among the demographic of over 65, the kind of prevalence increases to 494 cases per 100,000. And that was even just in 2011. And we know that this disease prevalence is increasing over time, probably a combination of true increasing prevalence and kind of increasing diagnosis. Unfortunately, universally, these diseases are typically progressive. And so it's important to diagnose them. And depending on the subtype, they're associated with significant mortality. So the kind of average time from symptom onset to death in one of the more aggressive subtypes of IPF, or idiopathic pulmonary fibrosis, is 3 to 5 years. And the majority of patients, just less than 50%, describe from time of symptom onset to being diagnosed with an ILD took over a year, and sometimes more than 3 years in up to 20% of people. And so that's kind of, again, a good fifth of kind of that time spent kind of wondering what they have and what they can do. So again, it's a rare cause, so when to suspect it, and the internists honestly will do most of the heavy lifting in trying to figure out when to suspect it. In general, middle or kind of aged or elderly patients with dyspnea, after excluding or adequately treating other or non-respiratory causes of dyspnea. the person's had a chronic cough for 2 to 3 months, at least your spidey sense should be going off. Certainly, if they have a family history of interstitial lung disease and they start to develop symptoms, that should raise your suspicion. And even with a kind of, history of the more common causes of shortness of breath, right? Asthma or COPD, and they're not responding to appropriate therapy, at least kind of go back and rethink about whether there could be something else going on. If you get pulmonary function tests as part of your evaluation, look for restriction. If you hear any crackles on exam that we'll talk about, and then x-rays are non-specific, unfortunately. They're a good kind of initial preview of what's going on in the lungs. And, many times the conclusions will be kind of no active disease, and then kind of buried in the report may be subtle findings that of increased interstitial prominence or chronic scarring or fibrosis or low lung volumes. Those keywords should kind of say, all right, there's something else going on. There's nothing acute, but definitely something there underneath the surface. And this is just an x-ray of interstitial lung disease with this is a beautiful one that you don't often see, of some honeycombing here at the bases. So there are numerous classification systems for ILD over the years, starting kind of in 1960s with the Hammond-Rich classification. The big one to know is kind of, is it an identifiable or known etiology of interstitial lung disease, or is the etiology kind of unknown? And so in the etiology known section, right, we're looking at things that people may expose to as part of their job. So asbestos, silica, hard metals, especially kind of at the VA hospital, there's a kind of a lot of burn pit exposure. So we're trying to kind of understand how those risk factors come into play for them. Other organic exposure, things like birds, hay, mold, drugs. So, macrobid for recurrent urinary tract infection, amiodarone, chemotherapies or radiation, underlying connective tissue disease, and this is a whole talk in and of itself, rheumatoid arthritis, myositis, scleroderma, Sjogren's, all of them can affect and cause an interstitial lung disease. Smoking kind of can be a risk factor for kind of desquamative interstitial pneumonia, respiratory bronchiolitis, ILD, or Langerhans cell. If you haven't noticed already, we like the ABCs of ILD. We like abbreviations. And then kind of moving over into the unknown categories. So these are kind of rare cases that we won't talk about today. LAM or lymphangioliomyomatosis, it's a cystic lung disease. Kind of a more granulomatous disease or sarcoid. And then there's a huge category of idiopathic interstitial pneumonia. So, right, not all idiopathic means IPF. So we have IPF and then we have non-IPF, right? So non-specific interstitial pneumonia, cryptogenic organizing pneumonia, lymphocytic interstitial pneumonia, acute interstitial pneumonitis. Again, the alphabet soup. And so let's kind of break it down to the more common ones that we see. So if we break it down kind of by prevalence, about 20% of the cases that we see are IPF, another 20% hypersensitivity pneumonitis, another 20% connective tissue disease. 20% is a good number to remember. Sarcoid, and then kind of pneumoconiosis is about 10%, and then kind of the other ILDs is about 10%. So you can't say like, oh, I've got ILD, you're most likely to have X, right? So it requires a little bit of work to try and figure out the subtype. And, even though they all affect the same location of the lung, the interstitial space, the ILD subtype does matter. So looking at the solid line here, representing kind of IPF mortality, you can clearly see that IPF subtype has a much more aggressive path, and people are more likely to have a higher mortality. And then kind of within there, you can follow suit. We literally have a group unclassifiable, right, where we don't know. And then kind of more chronic HP or connective tissue disease have a better mortality. So the subtype does matter. And so here kind of is a little depiction of, of the journey of patients with interstitial lung disease. So the journey is not smooth, and that there are many delays. Unfortunately, the primary care doctors usually shoulder a lot of the responsibility in terms of getting this started and carrying the patient through. Patients initially present with symptoms. The primary care doctor has to work on excluding other causes, then refer to pulmonary, potentially to an interstitial lung disease center, as this is a rare lung disease. And so managing this does take a little bit of kind of additional experience to feel comfortable managing these. Then these patients get reviewed at a multidisciplinary diagnosis discussion. Then the patients finally get diagnosed with a subtype and treatment, and then death. So, this in terms of time, this was these numbers, these days are from a English study. So obviously with all the caveats that, we're on this side of the pond and the healthcare system is different. So between the onset of symptoms and pulm referral, it's actually pretty fast. So kind of 48 days or so. The time to referral to an ILD center was longer, right? 290 days, with the max being almost 2 years. And then kind of about 540 days from time of symptom onset to diagnosis and initiation of treatment. Again, is if this is IPF, we're talking about death in 1,826 days. So these patients are spending a significant portion of their time trying to figure out what their underlying disease is. And there's a kind of an interest at an international level to try and identify these barriers and how ILD centers can be better at educating kind of both the primary care providers, other pulmonologists, the patients themselves, trying to increase awareness for these diseases. So after diagnosing an ILD, what's next? So I think hopefully made clear, referring to pulmonary early, we know that delay in referral to an ILD center and a delay in diagnosis of the specific ILD is associated with a higher degree of mortality. So the thing that can be very helpful is really, getting these patients set up and kind of ready to go, so that the first visit with a pulmonologist or an ILD center is the kind of the maximal, the kind of more bang for your buck, so to speak. So things that can be very helpful to help smooth that is to assess the severity of symptoms. That will help the primary care providers determine the urgency of referral, or at least the need for oxygen while they wait to be seen. Time and time again, patients feel like they're just, Google searching kind of pulmonary fibrosis, and the first hit that usually comes up is you're dead in 3 to 5 years, which sparks appropriate significant anxiety, depression at both the patient level as well as the caregiver. And so providing a reliable place for information, I cannot stress that enough. So the Pulmonary Fibrosis Foundation is a great website. I actually put it in my Epic Smart Phrases, whenever I'm you have an ILD, go here for additional information. It has great information. It has support groups for both patients and their caregivers. They have pulmonary rehab exercises that they can do at home via video. So it's a good support network for patients to navigate, because most of them don't know somebody with this disease, unlike a COPD or an asthma. So getting them to kind of link patients with kind of common symptoms is key. And then start looking for an underlying cause. And said another way is kind of assess the likelihood that kind of the interstitial lung disease is the scary one, IPF. So how do we do that? Again, I will save you the multiple iterations that the kind of these diagnostic criteria went through, but needless to say, kind of in 2018, the kind of most recent guidelines of how to diagnose IPF came out through the ATS and ERS. So basically, I like to reframe these criteria. Is this IPF or not? And so initially, if you have a patient suspected to have IPF, which I put there any interstitial lung disease, the first step here is to look at the underlying for a potential cause or associated condition. So how do we do that? A good old-fashioned history exam, labs, some functional testing in the way of PFTs and a walk test, a high-resolution CT scan, plus or minus a biopsy. So First things first, so history. So the pattern of dyspnea matters. So is this kind of a slow progressive dyspnea, right? Have the patients just gradually started to do less? And many of them, especially the vets, will say, oh no, I'm not short of breath. It is, well, I just stopped doing that. I just stopped carrying out the trash. I just stopped, I just stopped going upstairs. And then you explore that further. And the reason is because they're short of breath, even though they may not kind of characterize it as such. So it's a little bit of a detective hat to put on. Many of the primary care doctors are really used to that. The other kind of pattern is this rapidly progressive. If they were fine in January and all of a sudden in March, we're really in trouble, right? Then both your concern level heightens, right? For them. The other piece is this fulminant. So many of these patients can present into the ICU, especially kind of myositis associated ILD with fevers, hypoxic respiratory failure will look all the world like an ARDS patient. See if they can identify any events, kind of infection, travel, exposures that are associated with the decline. When you talk to them about their cough, unfortunately, that's not something that's going to help you specify the underlying cause. What is a good thing to do is look for alternative causes for both for patient kind of quality of life, right? So not all cough is ILD, right? And look at them for upper airway cough syndrome. Do they need, some intranasal steroids, reflux, and then do a good review of systems. So rashes, arthralgias. So it's, all of us have aches and pains these days. So kind of looking at the pattern. So if people are really complaining of kind of the base of the thumb, that's a little like more osteoarthritis. They're really talking about joint stiffness, kind of the MCPs and the PIPs, as well as joint stiffness lasting more than 30 minutes. I'm more concerned for kind of some sort of autoimmune or inflammatory arthropathy. Looking for muscle weakness. This is not something that patients are going to volunteer. I had a pregnant lady who came in with interstitial lung disease, and I asked her, I was like, do you have trouble brushing your hair, brushing your teeth? She said, yes, I've had my husband do my hair for the past month because I just cannot lift my arms. Turned out she had really bad myositis, but they don't think it's relating to the lungs, so they're not going to offer this. GERD, and I put every iteration of GERD because I am still finding constantly impressed with how people characterize it. So I don't have reflux, but I have acid reflux, or I have indigestion, or I have nausea, or I have heartburn, or I cough when I lay down, or I cough when I eat. Food's getting stuck, right? All of these symptoms that may not be the they give you some insight into the underlying cause, like an autoimmune disease, or at least a factor that may potentiate the ILD. Looking for dry eyes or dry mouth, that may be a symptom of Sjogren's. I had one patient who came in and I said, oh, your teeth are great. Are they real? He's like, no, I flew to India 10 years ago in my 40s to get all of them pulled and replaced because my dentition was horrible. Turns out he had really bad Sjogren's. Raynaud's, so looking for fingertips kind of changing color in the cold weather, or with anxiety or certain triggers. And then a key is looking at exposures. So again, patients actually doing telemedicine over the past year has been nice because you can actually see where people are living and kind of see if there's any kind of things that you can peer up in the background. I had one person put the phone down. I was looking at the ceiling and I was like, that's mold up there. What's that? We don't often get that lucky. So asking for specific questions. So water damage, house ever flood? Do you use humidifiers, hot tubs, saunas, jacuzzis? That might suggest more of a hypersensitivity pneumonitis subcause, and we'll talk about these in a minute. Do you have any down feather bedding or coats? Do you have a pet bird? And I put pet in quotation because someone said, I don't have a pet bird. Later on in the visit, 3 visits in, but I have a bird. That's not a pet. It's okay, great. So all how you ask the question. Asking about medications and radiation treatment. So pneumotox.com, I literally have it when I do pulmonary consults, really looking for any drug, and it's actually maintained by someone in France, to basically look to see if there's any drug toxicity associated with drugs that they've been on. May lend you to more of a drug or radiation-induced interstitial lung disease. Asking about current and former occupations and hobbies. So there are kind of classic exposures: glass cutting, woodworking, sandblasting, mining, and really got to get into the nitty-gritty of what they're doing. Are they just are they in an office? Are they actually in there? Is the dust being kind of ventilated in or out? This is kind of, in and of itself, could be like an hour-long visit. We know that smoking is a risk factor for many of the interstitial lung disease. So are they using, when's the last time they used? I have a young 30-something-year-old lady who she's like, show me the visit. No, I'm not smoking. And then I follow up with her. She's like, nah, I just didn't want to say I am still smoking. She had bad kind of descriptive interstitial pneumonia. Do they have a family history of interstitial lung disease? And then do they have any known kind of autoimmune disease or any of these symptoms that we talked about before that may clue you into an underlying connective tissue disease? So the next step in trying to identify the underlying cause is the exam. And so I put exertional hypoxia, which won't necessarily tell you the underlying cause, but will certainly help you understand the severity. So many people will come in and their resting saturation will be just fine. And then as soon as you get them up, and you don't even have to walk them that much, throw a pulse-ox on them, walking up and down kind of in the clinic. And if they desat, right, then that's one of the things that you're really concerned in when you talk to the pulmonologist or the ILD center that you're referring, saying, I have someone who's hypoxic, rapidly progressing, right? We're going to like move hell and high water to get those patients in fast. Looking at exam, are you having kind of any dry crackles or rails? For the medical students, think about basically these adventitious sounds that will sound like kind of peeling Velcro back or kind of rubbing your hair together. And those can be suggestive of interstitial lung disease, not specific to IPF. Clubbing can happen anywhere between 7 and 72%. So looking at their nail beds. So instead of that convex kind of normal angle, on the wrong screen, sorry, the normal angle between the nail bed and the finger itself is that kind of more in this kind of concave 180 degrees. So again, it's not specific, it's just telling you that there is potentially some hypoxic mechanism. Mechanism for clubbing is not fully understood, but probably involves kind of increased capillary growth pattern and VEGF that we can talk about another time. And then looking for autoimmune features, so joint deformities or effusion, rashes, or mechanics hands. Let's take a look at these. So this is the a shawl sign. So basically think of it as like you're wearing a shawl and you'll see kind of a erythematous or kind of a purplish rash in that location, a V-neck, as the name described. This patient has a narrow oral aperture, so you may see it in the intensive care unit or under anesthesia when you're trying to intubate these patients that can't open their mouth. That's suggestive of scleroderma. Heliotrope rash, this kind of purplish discoloration. This is like very extreme that you won't see perfect, but it can be seen in myositis, and the heliotrope is because it's a beautiful purple flower. Looking for Gotrin's papules or kind of polygonal papules over the bony prominences. Can be really subtle. And then finally kind of fissuring of the hands or fingertips can be seen in especially aggressive myositis. Many people who work in trade may have dry hands. You ask them, do your hands always look like this? Is this what, and many of them will tell you, oh no, this is something kind of more recently that's a problem. Yes, how often, I'm just seeing a note, how often is there a prior history of severe respiratory viral infection, influenza, perhaps too soon? So certainly we're learning about the kind of progressive nature of these, but many times that having a superimposed infection will set these people over the edge. So if they had it before and then all of a sudden they get COVID, it may bring them to attention more readily. I have actually an EMS patient who I'm taking care of now who turns out had myositis and then got COVID, and that's what brought him to attention. So the next step in identifying an underlying cause is looking at labs. So there's no consensus of what serologists to send. It's a good start as a kind of an intensivist or internist rather, to start with an anti-nuclear antibody by immunofluorescence specifically, because it will let you try to distinguish the pattern that may be suggestive of specific subtypes of connective tissue diseases. So for instance, you see a nucleolar pattern, you're highly suspicious for scleroderma or polymyositis. Certainly early referral to rheumatology will be really helpful from a pulmonary perspective, because we say, oh, does rheumatology think they have an autoimmune disease? All right, then that may help me say, I don't need to biopsy this person if we're really strongly, if we really are confident in the connective tissue disease diagnosis. So I'm going to go through this exhaustive list, but basically kind of antibodies. So I told you kind of definitely send an ANA, rheumatoid factor, CCP. If you have evidence of a multi-compartment syndrome, you can send some ANCAs to look for GPA or vasculitides. If you see rashes or proteinuria, thinking about sending a dsDNA or Smith to look for lupus. If you have pulmonary hypertension, really looking for kind of an anti-centromere antibody. Maybe that's an additional one that you send to look for CREST syndrome associated with scleroderma. If you see kind of skin thickening and kind of retraction of the hands, some digital pitting on the or some narrow aperture mouth, maybe you want to send an SEL70 to look for scleroderma at the same time. If they have dry eyes, dry mouth, and SSA-B, any of the rashes that I told you about, polymyositis or dermatomyositis, and you can start with kind of an anti-Jo1. And I just want to highlight this because this is super important. Kind of anyone with skin or oral ulcers and a rapidly progressive shortness of breath, got to screen them for MDA5. That's super rare, but unfortunately when it happens, it's pretty catastrophic. These patients I had one patient who literally got referred to me in January, and despite prednisone, Cellcept, Cytoxan, IVIG, ended up getting admitted and died in April. So within 3 months, and like I was putting on immunosuppression in a really uncomfortable way. So the next step is kind of looking at functional testing. So, these PFTs, so you need kind of spirometry, lung volumes, and diffusion capacity, because many patients may have normal spirometry or pseudonormalization of lung volumes if they have combined pulmonary fibrosis and emphysema. 6-minute walk test is great. It's like cherry on top for us, but you don't necessarily have to do the full 6 minutes, right? If you're walking in your office, like, 100 or so feet, are they having exertional desaturation? Do you need to get them set up with oxygen, at least in the meantime? Anyone who is less than 88%, they need to be started on oxygen. There's so many myths that the Pulmonary Fibrosis Foundation does a great job in trying to debunk for patients with oxygen use. All of these things help to triage the urgency of referral and kind of helps me when I see these patients determine whether or not they're a candidate for invasive biopsies. So back to kind of the ATS algorithm, we've gone through the potential cause. Now the biggest kind of tool in our toolbox is the high resolution CT. So the CT matters. So it has to be high resolution. You can see here anything that we define as high resolution is kind of less than 2 millimeter slices. You can see here in a conventional CT scan, there's some kind of non-specific kind of findings here. And then kind of this is better amplified at the same time by high resolution CT. And so if you're suspicious or you see it, the person needs a high res. The amount of time that I have to see people and then I have to get another one, that can like totally change. Honeycombing that wasn't seen on the conventional CT can become like just in your face on the high resolution. Getting inspiratory and expiratory views are important. You can see here this, patient maybe has some mosaicism where some areas are a little blacker next to areas that are a little whiter. So it's really accentuated in the expiratory view where you can see this kind of this persistent black area is suggestive of air trapping. And when I see that, like hypersensitivity pneumonitis is the subtype until kind of proven otherwise in my mind. Prone images, like nice, but not necessary unless you see kind of really subtle findings. So I wouldn't order that kind of consistently in people. A CAT scan or an angio for PE alone, it isn't enough. So the presence of contrast can sometimes make detecting ground glass. It can basically make the lung attenuation a little bit brighter. So it's hard to say whether there's ground glass there or not. And usually the PE is timed for the dye timing to assess for PE and not for kind of a maximal inspiration. So you see many people who are mid-exhalation and they get the CAT scan, it looks like there's a whole bunch of ground glass there, right? That may not be there, where the pattern may change based on kind of getting an adequate CT. So when we get a high resolution CT, what are we looking for? So we're looking for the dominant pattern, the fibrotic or non-fibrotic features. Fibrotic features are kind of these areas of reticulation, basically of inter and intralobular septal thickening. Looks kind of like small curvilinear lines down here with blue arrows. We're looking for honeycomb, these areas of kind of areas that are blacker than the adjacent lung, suggestive of destruction, outlined by a nice wall, and usually like them to kind of line up right along the pleural edge, and again, cherry on top, have kind of more than one row to suggest traction bronchiectasis. So you can see this kind of airway here is kind of ragged, right? Because there's differential of that fibrosis kind of underneath, pulling open the airway and creating that. So you see those and you're really concerned that there's fibrosis there already. Non-fibrotic features, so kind of these kind of ground glass nodules right here, more ground glass, mosaicism, this is a huge one, but basically areas of kind of areas of increased attenuation next to areas of decreased or blacker attenuation on the CAT scan. And then certainly consolidations, which may be suggestive of kind of non-fibrotic features. The next thing we look for is the distribution. Is it upper or lower lung zone predominant? Is the pattern of involvement kind of axial or along that bronchovascular bed, or is it more peripheral? Are there any additional findings on the CAT scan that may make an underlying cause more visible? Do they have a pleural or pericardial effusion, like patients with connective tissue disease? Do they have air trapping? Do they have a dilated esophagus? And then get previous CAT scans. So we don't know whether it's old or new findings. We don't know how long the findings are there. It really helps decide the rapidity with which we are going to start treatment, and helps me say, is it part of, usually these patients are coming for attention when they're feeling worse, right? So what it's hard for me to say is, if we have one kind of snapshot in time, is this, ground glass because of an acute viral infection, or is it part of the underlying interstitial lung disease? So if they have previous CAT scans, tell them, go get them on a CD, bring them with you so we can look at the images. So the way kind of ATS boils this down is basically, when we're looking at the high resolution CT, we put them into one of four buckets. And basically, is it in terms of how likely is this a kind of a UIP pattern? And UIP, or usual interstitial pneumonia, is the pathologic and kind of radiographic description that's associated with many diseases, but more specifically idiopathic pulmonary fibrosis. And we'll talk about kind of on the UIP pattern on a high-res CT has evidence of reticulations, traction bronchiectasis, minimal ground glass opacity, and has honeycombing in a basilar and subpleural distribution. If you have all of these features but don't have honeycombing, then you're assessed, or you're classified as a probable UIP pattern on CT. Indeterminate is kind of their unusual features. They may be subpleural predominant. They may have less than 5% lung involvement, and that there are some features that are suggestive of a non-UIP. So maybe there's like some here, kind of some axial extension, but not enough to say this totally doesn't look like IPF, or excuse me, UIP. And then the last bucket is alternative, that this, IPF is, or UIP is really unlikely, that these people have micronodules, they have consolidations, they have cysts, mosaic or air trapping, they have lots of ground glass. If they don't have kind of the basilar or subpleural predominant, right? If they have an upper or mid lung zone, if they are perilymphatic or peribronchovascular. And again, what we're saying is the kind of the high-res CT predicts a certainty of finding UIP on a biopsy that ranges anywhere between kind of 30 and 95%. So if you're seeing kind of, you have a probable UIP pattern here, right, on a CAT scan, then the likelihood of potentially finding a UIP on biopsy is going to be about 95%. And that is in contrast to the kind of the alternative diagnosis, where that kind of that degree of confidence is a lot lower. So let's say you're not you're in the alternative bucket. What other things can happen, or what other diseases can you have? So there could be a non-specific interstitial pneumonia pattern, and that is usually classified with ground glass here, right? And for the medical students, are you ground glass versus consolidation, because in ground glass you can still see the underlying vasculature airway through it. There can be some subpleural sparing, just as it sounds, that maybe literally just adjacent to the pleura, there is kind of a notable absence of the ground glass. Usually is more lower lung zone predominant, and this is the most common radiographic pattern seen with connective tissue disease. with the exception of rheumatoid arthritis, which is kind of a UIP pattern itself. Another common alternative diagnosis is hypersensitivity pneumonitis. So basically exposure to a myriad of different antigens, whether that be mold, birds, down bedding, hot tubs, farming. And so in its non-fibrotic form, people can present with central lobular nodules, areas of air trapping that we kind of saw a couple of slides ago. These can progress to fibrosis, and you can see here these patients have kind of upper or mid lung zone reticulation that seems to spread in along that bronchovascular axial distribution. The key treatment for these patients are antigen avoidance plus minus some steroid or steroid-like medication. And then finally, kind of, again, common alternative patterns, organizing pneumonia, usually classified as kind of peripheral or peribronchial consolidation or ground glass, usually from an underlying trigger like infection, aspiration, autoimmune disease, immune deficiency, and drug toxicity. If none of those are kind of the cause of organizing pneumonia, that's when we call it kind of cryptogenic organizing pneumonia or cough, but really have to do due diligence to rule out other things. And these are typically steroid responsive. So as you can see, this algorithm is really focused on kind of the likelihood of you having IPF. So if you have IPF, that's great. If you don't have IPF, your journey doesn't stop there, right? We still have to figure out what's going on. So the next step, you've had a CAT scan, you've been labeled as either having UIP, probable UIP, indeterminate, or alternative. Then we get to have a kind of a big powwow. So the multidisciplinary discussion includes pulmonologists, thoracic radiologists, pathologists, and rheumatology when we're really lucky. And we sit around at a table, and we're likely now in the setting of COVID, we sit around in a Zoom meeting. And then we talk about kind of variable questions. So the biggest is, do you biopsy or not? What's your confidence in the degree in your diagnosis, and kind of if there are any treatment questions. So, is definitely better than doing this on your own, meaning having a group discussion, but it's still the inter-observer agreement and diagnosis is only kappa score about 0.42. It's higher if there's kind of an ILD expert pulmonologist included, but like a kappa score, basically agreement in the diagnosis increases to 0.53. We know that it increases confidence in diagnosis compared to people trying to diagnose it by themselves, right? More kind of power in numbers, so to speak. And we know that kind of reviewing a case at an MDD changed the diagnosis in about 30 to 40% of cases in one series, and treatment in up to 45. So these are kind of very important to do. I started one at the VA, so it's a task because it's a really it's our biggest I should say, our most precious resource is time, and many of us, we're all strapped for time. So after, one of the things that we use is kind of to decide whether a biopsy is necessary is looking at the high resolution CT. So you can see, I showed two, so there, just so you know, there are two classification guidelines that came out around the same time, ATS and then Fleischner. There's a lot of overlap that I don't think that we need to kind of get into unless someone wants to talk afterward. I'm more than happy. But basically, if you have a UIP pattern based on the CAT scan, then typically a biopsy is not recommended, and it can just be associated with increased risk. If they have a probable UIP pattern, ATS says a biopsy is recommended, although kind of behind closed doors, I think many people didn't feel kind of totally convinced with that recommendation, people talking to people on the panel. Whereas Fleischner says, you know what, if you have a probable UIP pattern, meaning peripheral, basal, or predominant, and all you have is the absence of honeycombing, then you probably don't need a biopsy if these people are older than 60 and you've ruled out the other cause. Remember, the first thing that we did was look for another cause. If you find an autoimmune disease, this is not likely IPF. The the indeterminate category and the alternative category saying biopsy is recommended. And there are caveats within there, right? If I have somebody who has a slam dunk organizing pneumonia and has myositis, unless I see something kind of concerning where I need to look for infection, or I need to, if I'm worried about cancer, I'm not going in and biopsying these people. So what are our biopsy options should you need to pursue that path? So we have kind of transbronchial biopsies where you can see here really small sample size of 0.1 to 0.3 centimeters. There's an adequate sample in about 78%, but the diagnostic yield of identifying an interstitial lung disease is only about 36%. So I will only do these in patients who I think have sarcoid or maybe have a hypersensitivity pneumonitis, where I'll check kind of a transbronchial biopsy, plus I'll do a BAL with CD4, CD8 ratio, and then doing a cell count diff to look for lymphocytosis. This is a less invasive option, so the risk of bleeding is lower, the risk of pneumothorax and mortality is lower. Cryobiopsy, you get a little bit of a bigger piece, you get a good potential to get an adequate sample. The diagnostic yield for diagnosing an ILD is pretty good. There are risks, so just over a 1% chance of exacerbating the interstitial lung disease, a 5% risk of bleeding, 13% of persistent air leak where people need a tube, and a 3% mortality. Most of this is disease specific, not procedure related. And then surgical lung biopsy, gold standard, right? So if we want tissue and we're really unsure, this is where we should be going. Gets you about 4 centimeters of tissue, adequate sample in 100%, and then a diagnostic yield in about 90%. This is associated with, 6% chance of an ILD exacerbation, air leak, 3% can have delayed healing, and the mortality is described anywhere between 3 and 16%. Specifically related to the biopsy itself, it's probably more in like the 2 to 3% range. So basically, when we think about biopsy, you have to weigh the risk, the amount of tissue you need, and the kind of the diagnostic yield with what are the risks to the patient, right? If you have somebody who is on oxygen, who has a DLCO less than 40 or an FVC less than 50, I'm not touching them with a surgical lung biopsy usually, right? We say, okay, patient, like there's a certain degree of uncertainty that we'll have to live with and not knowing, right? And so this is a kind of a discussion that you really need to balance the risks. Just because you can biopsy doesn't necessarily mean that you should. So you've kind of gone through this, there's no underlying cause, you have a CT pattern that shows UIP, the MDD agrees, you didn't biopsy, they have IPF. So again, all IPF kind of patients should have a usual interstitial pneumonia pattern on CAT scan or on pathology if you biopsy them, but not all UIP is IPF, right? So there are many other diseases that can be associated with UIP patterns. So familial IPF, connective tissue diseases, especially RA, drug toxicity, HP, and asbestos. And what are you going to see? Some architectural distortion, some fibrosis with honeycombing. You're going to see some fibroblastic foci. You're going to have patchy and temporal heterogeneity, where there'll be areas of disease lung next to areas of undamaged lung. The clinical course of IPF is highly variable, and so people can have a slow progression, can have a more rapid progression, or can have a kind of a stepwise decline here. But the bottom line, these are kind of older data, but still kind of the average life expectancy of around 3 to 5 years. Who is going to do worse? We know males do worse. If you have a drop in FVC by more than 10% in the first kind of 6 to 12 months, walking less than 679 feet, desaturating and needing oxygen, the presence of secondary pulmonary hypertension, hospitalization, it's kind of an independent risk factor, 14% risk of death or lung transplant, or death during readmission in 90 days. If there's kind of evidence of strep or staph, that's kind of been associated with a worse prognosis. Treating IPF, we know a lot of things that don't work. We know that a lot of things don't provide benefit, and then we know that a lot of can provide harm. So we no longer use kind of monotherapy, of prednisone, or any immunosuppression for these patients. 2014 was a great year, and that was kind of release of 2 drugs or antifibrotics to treat patients with idiopathic pulmonary fibrosis. So pirfenidone inhibits kind of TGF-beta induced collagen synthesis. It decreases the kind of extracellular matrix, and blocks the metagenic effect of profibrotic cytokines and fibroblasts. So does a lot of stuff. Dr. Letter has a kind of a great review in New England Journal of Medicine, and the kind of this is the point at which we think that pirfenidone has its effect. It was studied, I'll tell you, kind of in the interest of time, in 2 capacity trials that showed promising but inconsistent effect, and so patients got moved, or another trial was required. Basically, you had to be You had to have definite UIP on high-res CT or have a probable diagnosis. You had to have an FVC above 50, a DLCO above 30. You couldn't have obstruction on PFTs, and you had to at least be able to walk 150 meters. What it's shown is that compared to people who did not get drug, people who did get pirfenidone had a decrease about 48% in the likelihood of a decreased FVC or death. Compared to people who did not get the drug, you had about a 45% less of an FVC decline, about a 28% change in the walk distance or death, without any kind of true impact, and then a kind of a decreased progression or an improved progression-free survival, and that was a composite of FVC or death. So it does pretty well. Looking at mortality, death from any cause, there was kind of a significantly reduced effect, and it was specifically related to kind of IPF. That was significant, although the numbers were really small, and only when we pooled all three studies, ASCEND and the two capacity trials. For that study that I just showed you alone, the ASCEND trial, there wasn't a significant reduction in mortality. The other big drug, nintedanib or OFEV, is a triple tyrosine kinase inhibitor that affects platelet-derived growth factor, VEGF, and fibroblastic growth factor. These were kind of independently studied in two kind of feel better, and so you got to talk to them a lot about the side effects. When they looked at the kind of FVC decline, it only reached significance when we say that the nintedanib slowed down the rate of decline of kind of greater than 5%. So how do I choose between the antifibrotics? So they both have comparable efficacy, so in the mid 40% likelihood of decreasing FVC. They both cause liver toxicity. Pirfenidone can cause a photosensitive rash, nausea, fatigue. It's a higher pill burden, 3 tablets 3 times a day, and it may have impaired activity in those patients who continue to smoke. Nintedanib, a high rate of diarrhea, increased risk of bleeding on anticoagulation was initially reported, but that was kind of debunked. And there was an initial signal toward increased risk of cardiovascular events that so far hasn't been seen in kind of post-hoc trials. We have more experience now kind of 5 years later, so kind of based on a lot of meta-analysis of many trials that were kind of done very differently. So pooling these trials have some kind of statistical consequences. It does look like being on any antifibrotic was associated with an improved mortality with a relative risk of 0.55, and it does seem that they are decrease the rate of acute exacerbation, more so in the nintedanib kind of subgroup compared to the pirfenidone. Despite that, you know, there's a relatively low adoption of these antifibrotics. So among privately insured and Medicare Advantage beneficiaries, only about 26% with an ICD-10 code of IPF had ever filled a script for an antifibrotic. Men were more likely than women to receive a prescription, and about 43% of them discontinued the medication at some point. And despite there being a lot of grants to support these, the out-of-pocket expense for many of these patients were at least $400 a month. So it's a lot. A brief treatment kind of discussion on treatment of non-IPF ILD. So it's a huge catch bag. So anti-inflammatory are in our toolboxes, so steroid and steroid-sparing agents. And then we're learning more about how to use these antifibrotics in these patients. There are a lot of active ongoing trials to explore when and if to use nintedanib or pirfenidone. So just so an example kind of for RA-ILD in the patients who had a non-UIP ILD CT pattern, these patients seem to do better compared to the people who had a UIP pattern, where they seem to progress more in the IPF. So should we be treating these patients differently based on their subtype? There's an ongoing trial looking at pirfenidone and RA-ILD. And again, I just put these up and kind of, this is a whole talk in and of itself in terms of how we're using antifibrotics in non-IPF ILD. Needless to say, I'm waiting to show that there's actually true progression of the fibrosis before I'm adding these drugs on. Acute exacerbations are something that you're going to see high risk of kind of mortality in these patients. Again, they're characterized by worsening in symptoms, the presence of diffuse ground glass on CAT scan. Really the care is supportive. You exclude infections, you treat for infections empirically, give steroids, but we don't know how much and for how long. Lung transplant for interstitial lung disease. If it's an IPF patient, refer them early for a transplant evaluation. That way that anything that needs to be corrected can be done. Each transplant center has different criteria and comfort for different comorbidities, but there are some high-risk features that primary care doctors can help with. So obesity, if they have significant peripheral vascular disease, if they have uncontrolled connective tissue disease symptoms, that may be a red flag. If they have significant renal dysfunction, if they have bad gastroparesis, if they're really sensitized, have a lot of antibodies that will preclude us from finding a donor that they won't have an antibody against. And certainly if they're deconditioned or frail, we know that's an independent risk factor for kind of poor post-transplant outcomes. I put this up in terms of the abcde bundle. So this is something that any provider can do and look at and help at some point along this continuum. So assess the patient's need, back them. So, give them some education, give them support groups, give them advocacy groups, send them to pulmonary rehab to improve their endurance, vaccinate them. That's a whole lot that we won't talk about right now. Encourage them to stop smoking, right? Managing their comorbidities that I'm going to get into in a minute. We talked about kind of disease modifying drug, but notice that's just one arm in this kind of spectrum of things that we can do for patients. And as they kind of near end of life, talking to them about kind of end of life discussions or treatment limits of what they do and do not want. In terms of comorbidities, this is again something where it takes a village, so not just the pulmonologist, the kind of internist, the cardiologist, endocrinologist, right? Many of them have concomitant emphysema, lung cancer, so making sure we're screening for those, obstructive sleep apnea, being still vigilant or aware of other causes that just because they have ILD doesn't mean worsening symptoms can all be related to that. Coronary artery disease, pulmonary hypertension, progression in valve disease, gastroesophageal reflux, we think is an independent risk factor for ILD progression, but haven't shown consistently that treating it will actually slow down the rate of decline. Diabetes, we do that to people with giving them a whole bunch of prednisone. So thank you, internists and endocrinologists, for helping us with that. There are too many new drugs that I do not know. And then depression and anxiety. This is huge. Medication, CBT, and support groups are key.